Thanks so much. It's a pleasure to be here. We'll shift gears a little bit about surgical treatment for Afib and concomitant valve disease. Um, Here you go. Here are my disclosures, specifically related to this talk. Borrow some slides for the AtriCure company, but other disclosures are not relevant for this talk. So as we know, most of us understand that Afib it's clearly a big medical and financial problem and burden for the United States, and only 1/3 of atrial fibrillation is treated during heart surgery. So clearly a very undertreated disease. And currently there are more than 33 million people still suffering from Afib worldwide. And as the population grows and ages, there's clearly a need for atrial fibrillation treatment. Clearly the burden is going to increase, estimated to be 12 million in 2032. Many studies have shown a clear relationship between atrial fibrillation and heart failure. And clearly that the restoration of the sinus rhythm improves ejection fraction, and especially so in patients with severe left ventricular hypertrophy, with other valvular disease, and the restoration of sinus rhythm in these patients, even with cardiac valve disease, is clearly beneficial from a heart failure and survival standpoint. In 1995, one of our surgical giants, Jim Cox, developed a technique alongside with the electrophysiologist, a cut-and-sew surgical maze procedure, which is really transforming in terms of surgical treatment for atrial fibrillation. This technique initially was described by Jim Cox, and as a Cox Maze 3 procedure, it involves literally cutting the right atrium and the left atrium into maze little pieces and then sew back together. So as you can imagine, clearly it's really a lot of needle holes and potential bleeding, and didn't really take off until different energy sources became available. This is a meta-analysis systemic review of really specifically looking at whether or not the utilization of different energy sources compared to cut-and-sew technique is beneficial. And this systemic meta-analysis review clearly showed that the sinus rate conversion between the classic cut-and-sew that Jim Cox developed and the alternative energy sources are similar. So this is just a quick diagram of what surgical maze look like, essentially isolating the pulmonary veins and creating ablation lesions to the tricuspid mitral annulus, and really interrupting the micro and microartery entry circuit for atrial fibrillation from an electrophysiology standpoint. And as you can see here, multiple sources have really demonstrated the cure rate, the potential cure rate for persistent or non-paroxysmal atrial fibrillation is upwards of 90%, which is really, really quite impressive, as evident by multiple studies. So why is it that this type of procedure in surgery is not occurring more common in concomitant valve operations? Well, I'm just going to go over a few studies really documenting why it should be done. This is an early study from Niv Ad's group, who is a protege of Jim Cox's group, really showing that answer the question whether operative risk is increased with additional Cox Maze 3 procedure to aortic valve or coronary artery bypass operation. And albeit this paper is only has 95 pairs of propensity matched patients, a relatively small population, but essentially the message was that the addition of the Maze procedure in other concomitant cardiac surgery operations did not add any increased morbidity or mortality. As we move on in the same group, as they get more experience, higher volume of patient and higher sample size, and on a similar note, looking at both concomitant mitral and tricuspid valve surgery, really the message of this paper, which is published in our premier journal, was no increase in morbidity was associated with this procedure in mitral and tricuspid valve surgical patients. In similar fashion, as the same group really look at the long-term outcome, out of 473 patients who underwent the Maze procedure with mitral valve procedure concomitantly, this study suggests the addition of a Cox Maze procedure with mitral valve disease has high degree of complexity but did not increase overall operative risk. So in even longer term outcome, on a similar fashion, they look at more patients. Now it's up to 711 patients, which also show that in addition to success of cure for atrial fibrillation, the procedure itself did not add any additional morbidity. So all those papers I showed you were early, but really small sample size. So as we get more experience for this type of procedure in a surgical fashion, this group in the New England Cardiovascular Study Group looked at really the STS database, over 20,000 risk-adjusted patients, and clearly showed that there's an increase in survival, at least in the midterm, and for patients who underwent concomitant procedures in other cardiac surgery, which included CABG and valve diseases. This, again, really increasing sample size, looking at specifically the STS database, over 10,000 patients, also risk-adjusted, really showing that the performance of the MACE procedure is associated with increased and improved long-term outcome in patients undergoing cardiac surgery. So more recently, a group of experts around the world really trying to answer the question what we should do as surgeons and provide expert guideline in reviewing many published literatures as well as expert consensus to identify the question whether or not we should, as surgeons, treat atrial fibrillation as a standalone procedure or as a concomitant cardiac surgery procedures. I won't go through, because of the time constraints, I won't go through the details, but essentially I want to draw your attention to the guideline, which is, number one, whenever you do mitral valve surgery from an open surgical standpoint, it is actually a Class 1 indication based on level A evidence to do concomitant MACE procedures in patients with previous atrial fibrillation. And what about other type of surgery in addition to mitral valve surgery? Well, it's also Class 1. Level of evidence is B. It's a little bit less strong, but certainly a Class 1 indication. So what's more importantly is that patients with atrial fibrillation who is scheduled to undergo surgery must have a multidisciplinary heart team discussion to really optimize what the treatment options are. And this is not just the STS, multiple other organizations, including cardiology, cardiac surgery around the country and around the world, also recommended the concomitant surgical ablation or MACE procedure as a Class 1 indication to treat patients with previous atrial fibrillations with other heart valve diseases. So to conclude, atrial fibrillation portends to poor survival, which we all know. A MACE procedure has been shown by multiple studies to cure atrial fibrillation up to 90% of the time. And the radiofrequency ablation and cryo lesions have similar outcome as a traditional cut and sew technique. And very clearly, after many evaluations from numerous publications and peer study reviews, it's a Class 1 indication for concomitant procedure during surgical heart valve operations. Now, Class 1, I always tell the residents, is essentially an error of omission. So if you don't do it, you go to jail. So it's important that we do that, and surgeons really consider doing this operation at the same time. These are some of my references, and that being said, thank you for your time. Appreciate the invite.
Yeah, thanks so much, Dr. Chu, and clearly a very large patient population Venn diagram intersection between AFib and valve surgery or valve disease.